I would like to start by introducing our first speaker, or speakers, Ms. Maxine, Izzy, and Susan Green. They'll be talking to us about route to successful listing. Ms. Maxine Izzy is an RN, NP. She's a certified transplant coordinator and an adjunct professor at New York University. She has been with the transplant division for over 10 years and has extensive experience. Susan Green is also a certified transplant coordinator and has been working with the transplant division for many years. Again, both have tremendous experience and they're well qualified to speak on this topic. I would like to invite both of them to the podium.
My name is Susan Green, and we're going to go through the route to successful listing. If you imagine some arrows that in between these boxes here going across the top, successful listing starts with first the referral to transplant, and we'll move through each of these in our presentation. So as the transplant coordinators, we're responsible for coordinating the patient's care through every step of the transplant process right up until they get their operation. Whether or not a patient's a candidate is a really complex and difficult process. It requires a lot of resources. And once a candidate is referred, we'll manage that entire evaluation with them. We help coordinate their testing to determine what if they're a candidate. We'll help explain the process, educate them about the risks, the benefits of transplant. We provide a lot of moral support along the way as well. And we're their main contact person during this process, not only for the patient, but for their family members as well. What we're doing during this time is we're building their profile, which we then present back to the transplant committee, which is everybody you've seen today. It's a multidisciplinary committee with the surgeon, the nephrologist, the social workers, the nutritionists, the pharmacists, some consulting specialists as well are part of the committee. So it's really not just one person that makes a determination if a patient can get on a transplant list. It's all of us together. So the first step in this patient's journey to get on the list is the referral. It's getting referred. So every medically appropriate patient deserves an opportunity to be referred for a transplant evaluation in a timely manner. That way they can reap the significant benefits of the survival benefits experienced from transplant. There's a lot of ways in which we can receive referrals, as you can see here. But since I highlighted the TX Access one, this is a new electronic platform that we're using, where we're really starting to see the benefit of streamlining this process of referrals, where providers at dialysis centers can submit referrals electronically, where required documents can get uploaded directly to our program, and if they can be reviewed in a really timely manner. It also enhances the continuity of care between the transplant centers and the dialysis facilities. And it helps get these potential candidates in our clinics in a timely manner, which is really crucial. There's no question, though, that the work our transplant liaisons do will ever be replaced by this electronic platform. This platform can only enhance what they do, but really, you have to imagine that in Brooklyn alone, there's about 50 dialysis centers, and we have 2 outreach liaisons. So, you know, while they can't be everywhere at once, it really, when they are there in the dialysis center, they really have a personal touch to this referral process. And it's a really personal journey. So this is why the humanness of this experience can never be, you know, overstated. They provide information to about the referral process, the evaluation process, how the transplant list works. They're really a crucial part of our team. So once we do get that referral and it comes in, some general information is requested about the patient, you know, some general information about their kidney disease, whether they're on dialysis, some demographic information, some insurance questions, obviously, mainly. Whether or not they have a social security number, as we heard before, is not a requirement. I can't overstate that either. So this general screening info, we put it into our database, and then a packet of information goes out to the patient. It has a lot of educational material about it, the description about the evaluation process. And now we also have a link that gets sent out to our patients too, which sends them to our website, where they can watch a nice educational video, which we spend a lot of time working on too. All potential transplant recipients have to have adequate financial resources, as Marcella covered in her presentation too. There's not really strict criteria for referral, but most patients with stage 4 or 5 kidney disease are appropriate for a referral for transplant. We really, physicians are encouraged to refer all medically appropriate patients for transplant. But this, if they can refer them earlier, that helps the process, because this way the patients have a chance to become educated about the process. They can get their evaluation done in a timely manner. They have a little more time to maybe start talking to family members and friends about potential living kidney donation. But, many qualified candidates are referred late in the progress of their disease. I mean, we see the majority of our patients once they're already on dialysis. But if, you can take into consideration that we've already stated this, that they can start to accrue qualified waiting time once their GFR hits 20 or below, we can start that evaluation process even before they get to that point. And that way we can do the workup in advance. And then the benefit to the patient is that their wait time, once they're eligible to start getting that clock started, is at the earliest possible time. So the goal for referral should be that all these candidates are referred, at least when the GFR is approaching 20. So to consider that once they're on dialysis, you have another set of new comorbid conditions that go along and, make the patients potentially sicker for transplant. So the workup, requires a lot of tests and procedures prior to being deemed medically suitable. It does take a lot of time. It can take months to complete. So really, the early referral will allow the maximum amount of accrued waiting time for the patient. Here are some common reasons why the kidney fails. A lot of our patients fall into the top two categories, diabetes and hypertension. We see it all the time. And it's important that patients understand, and we educate them about this, that transplant is not going to cure this for them. It is something that they're going to have to continue to treat for the rest of their life. But what transplant will do is help them return to a healthy lifestyle, much like what they had before their kidneys fail. A kidney transplant, restores their health. They have more energy, they have better concentration, better mental function. And once you get off dialysis, a much better quality of life. So every transplant program has their criteria for being on a transplant wait list. And that's what differs between transplant centers. These are our criteria for being on our transplant wait list. We have absolute contraindications and relative contraindications. The absolute contraindications are these. There's a lot up here. And really what it means is that if you have something from any of this, from this category, your risk to you to receive a kidney transplant is too high. These is what varies between centers, and it's really, quite broad, and the listing decisions are often based on close review of each specific patient's conditions, including, things whether they have things like coronary artery disease, peripheral vascular disease, chronic obstructive pulmonary disease. When those diseases get severe and they're not correctable, then the risk of the operation alone or the perioperative time for them is just too high. The survival, rates start to drop off significantly. So there's a lot of exclusion criteria here, but if you look closely, the absolute contraindication, you won't see anything about an age in here at all. We talked about this a lot earlier today. Age is not going to be a determinant of whether or not you're eligible to receive a kidney transplant. More than about a third of the patients on our transplant wait list are 65 or older, and half of them are older than 70. So we had a lot of case studies already, and almost every one of them was over 70. So this is a really important thing to note. You'll see here too that the second one on the list, active metastatic cancer. Active cancer is a contraindication to transplant, but if their cancer is treated, they can be referred for an evaluation. In fact, if they're in remission or if they're cured, then they're transplantable. So they'll need to wait for that period of time, to monitor for the recurrence of cancer. But during that time, they could be on the wait list and they can begin to accrue wait time. The relative contraindications are those, generally speaking, that these are conditions that can be reversed or corrected. We may not be able to transplant somebody who has something from one of these lists right now, but once these conditions are resolved, then we can proceed. If you look carefully, you're going to see a lot of terms here like non-compliance, deceptive behavior, ambivalence regarding transplant. What we're trying to do here is identify, before we list these patients or before we transplant, those behaviors that are likely surrogate markers for post-transplant behavior that might compromise their ability to partner with the team, might compromise the ultimate, successful outcome of the graft. Medical non-adherence conveys this idea that patients have been told to follow a recommended course of action with regards to their medical treatment, but they haven't done that. But you have to keep, we like to keep in mind that there's a lot of reasons for medical non-adherence, and a lot of those reasons can be corrected. They may not be educated about, or they may not be convinced of the necessity of taking their medications, but if we can get them in for an evaluation and start the education process, a lot of these issues can be resolved. We like to take, everybody in and really consider that a lot of these things can be helped with just education, repeated instruction. Active substance abuse, I don't know if that came up yet. It's obviously a contraindication to transplant as well, but for some people, the desire for a transplant might give them motivation to seek treatment for their addiction. So, we also will consider these as possible referrals too. These people can benefit from getting in and receiving that education as well. Limited care support, we talked about that earlier. It's the reason why this is really important is you have to keep in mind patients have a massive surgery and go home at 4 days. While they're not laying in bed and being spoon-fed, they're also not going to the grocery store and carrying the bags of grocery home. They're not taking out the trash. We don't want them to do the dishes or walk the dog or shovel the sidewalk, right? We need people. They need people there to help them through this time. And without that, it's a really difficult time for people to get through this process. So that's why as part of our really important part of our evaluation is to assess what it's like when they go home. Because not only that, they'll go home after a few days and then they got to come back and forth to the transplant clinic twice a week, sometimes 3 times a week. And then you're going to ask them to go to the pharmacy to get medications. And we don't want them taking the bus and the subway and walking. It's great to have someone to get you a ride and pick you up. This is where care support really is crucial your body wants to reject the kidney the most in the very beginning. So you need people in your court to help you through this, especially in the first couple of weeks or months. Someone brought up earlier psychiatric illness. These patients as well, they can be considered for transplant if they have sufficient support. It's really complex to evaluate them. We use a multidisciplinary approach, as Dr. Markel said before. We have psychiatrists, neurologists, neuropsychiatrists. So all medically appropriate candidates should be referred for transplant. Referred for transplant. And with that, I'll hand it over to Maxine.
Thank you. Didn't she? That was awesome. How can I top that? So my portion, I'm going to talk about the transplant evaluation process. I'll try to go as quickly as possible. As Susie pointed out, where a patient get an appointment, we check their insurance. This is the day they come to the clinic, and every patient interested in a kidney transplant must have a comprehensive evaluation. The evaluation is done to determine if a kidney transplant is an option for the patient, and then create an evaluation plan to have the best possible outcome for this patient. The evaluation process can take anywhere from 3 to 4 hours. We discuss tests and procedures with the patient. We discuss meeting the different members of the transplant team, because the day when most patients turn up, they're like shocked that they have to stay for 4 hours, 3 to 4 hours, and that they're seeing each member of the team individually. Inform patient about potential medical and surgical options for them, because for some patient that comes to us, transplant may not be an option. And so this is our team. Our team is comprised of a surgeon, a nephrologist, a nurse, the dietitian, the social worker, the pharmacist, the financial coordinator. As you see, everyone on our team did a presentation today. What we didn't mention today is our Immunology Lab. And they are a vital part of our team. They're the ones who test the patient for what we call HLA, DSA, and for something called CPRA patient, that develop antibodies. So thank you. I see some of them over there. Todd, thank you for all you do for us. I want to talk about the role of the transplant coordinator. Our role is vital to the patient. Education is so important. The transplant coordinator is a valuable point of contact between the recipient and the transplant team. The transplant coordinator is the patient linked to the transplant hospital and all the resources that they may need. We're also resources for them to take back information about what's going on with them to their dialysis center, to the social worker, to their nephrologist. We coordinate their care with other members of the team that they may need to see. We also coordinate consultation outside for them. So our role is we're like, I would call, we're the hunters and gatherers. So these are some of the education that we give our patients. We talk to them about the benefit of early transplant for them. And this is the education. We want to ensure that the patient understand the process. Because if they don't understand the process, it's very difficult for them to partner with us, the transplant team, getting them to their testing. So education, and I know I heard Dr. Markel talk about health literacy. So we find that when they don't understand, they'll turn up at a hospital, not knowing anything or saying they don't know anything. But sometimes it's understandable because who remembers what you had for breakfast a year ago? So we are constantly in contact with them by phone, talking to them, giving them feedback. We explain the complexity of the UNOS kidney allocation system to them, the length of time that they would wait on the wait list. We're like psychiatrists, believe it. We provide emotional support through the stressful experience that they're having trying to get on the transplant list. We allow patients and their support system to make informed decisions about whether they want a kidney transplant or not. We give them so much education that sometimes it's so overwhelming. We send them packages. We send them to our website to watch our new videos. And again, as Dr. Markel mentioned, this may not be enough because some patients may not even have a cell phone where they can access these videos. So what has been going on with us, the transplant coordinator, if a patient turns up and said, I couldn't access the video, then we manually still do the education with them. These are some of the testing that the patient get. They get lab work. And again, with our Immunology Lab, which is the HLA antibody typing and analysis that they do, the PRA, we do drug screening on patient if we know that they are known drug users. And sometimes we pick that up from the social worker assessment. As the coordinator, we're responsible for helping patients get tested. And so breaking barriers to transplant mean that while we send patients for testing, we're exhausting all therapeutic options available for these patients. So I could say, for example, a patient comes and this is a good patient, but before dialysis, when they did their echocardiogram, the ejection fraction was 25. We know that it's probably not a true 25. So what do? We don't send them away. We send them to a cardiologist to get them optimized, repeat the echo. If they need to get medication to bring that echo up, that's what we do. We exhaust all therapeutic options for them. We do cancer screening. Some of the screening are age appropriate. So if you are 50 and above, you start mammogram. We, the coordinator, I really do love getting the younger patient because screening is less, but we can be biased. Some screening I want to talk about is the CAT scan of the abdomen and pelvic that we do. When Susie put that slide up and say that diabetes and high blood pressure is a major cause of kidney failure. Now that does damage a lot of vessels that they have, it get hardened. And so if they have diabetes vintage, we have to send them for a CAT scan of the abdomen and pelvic. Doesn't mean that they won't get a transplant, because I know my good doctor here, Dr. Fenig, always look at the CAT scan and said, or Dr. Rochon or Dr. Suresh and said, I see a spot, we could put it here. So that's part of breaking barriers to transplant. Again, this belongs to the Immunology Lab. They do all of the testing for that. We try to explain as much as we can to patients. about this, but they're the expert. If you didn't know before, the transplant surgery itself could take anywhere from 2.5, that's an easy patient, to 3 hours, sometimes even more. I have sat in my office waiting for hours for the transplant team to come out because, we're trying our best with this patient. We also inform patient about the different donors that we have, living donor, what's a brain dead donor? What is a DCD donor? You probably heard about this all day today about the important factors in allocation. What is a KDPI? I'm not going to go through it. You're probably bored. The EPTS score, the calculated panel reactive antibodies, which is the CPRA. That one I can tell you is very important for us to talk to our patients about, because sometimes a patient may come and say, why can't I get a kidney? I've been on the list for maybe 5-10 years. Now, this patient may have had multiple blood transfusion. They may have had lupus, some autoimmune condition, pregnancy. And so these are the things that would cause a patient to have high antibody level. And normally when you do education with them, they understand. And so if you want to know why this is the classification system for a patient who is highly sensitized. So if they have 100% CPRA, they are on the nationally, they would be able, for every kidney that comes up, maybe you can help me more with it, Susie. If they're 99%, it's regional, and the CPRA is 98% or less, then it's local.
They get national priority for kidneys that they don't have antibodies. So if
it's 100%,
CPRA,
yeah.
And there's a kidney anywhere in the country that you don't have antibodies towards, you,
your name would come up
on the
list for that. Yes, thank you. We also talked to them, about their dialysis start date. This is new for us now, the donor service area, where if every OPO that is within 250 nautical mile off Downstate, we're getting kidneys from we're up all night. Please sympathize with us. We're up all night because the calls are coming in more. Our patients are getting prioritized now. Texas is calling us, Delaware, Connecticut, everywhere. We used to depend on the local OPO. Now we're sharing. And I'm pretty sure you remember one, was it you, Dr. Rochon, that was talking about it? About the new donor service area. Yes. So now let's get to the final listing process. So this is a very intense time for us when we present a patient. And again, remember I said we're the hunters and gatherers. So as the coordinator, when a patient has completed their tests, okay, we, the coordinators, bring everything together, summarize it. We use our electronic medical record system so that we could be accurate when we're giving information, the source documents, so that, to minimize harm by saying the wrong thing. And the team comes together, the social worker, everyone has an input, okay, regarding this patient getting on the list. We review the history, the exam, the labs, the diagnostic test, the consultation report. We review everything. And because the team is so focused on making the right decision for the patient, we have to look at everything. Because we're listening with the intention of finding the right kidney for the right patient. Some of the questions to ponder on are, if this recipient get a kidney with a long, cold ischemic time, would they survive? Or can they tolerate a kidney with a KDPI greater than 85%, the not so good kidney? So these are some of the things that we do talk about in our meeting. And on our selection or risk assessment page, we would check off whether or not they are candidates for any of these. At the time of listing, we can either approve a patient. Successful listing have different categories. So they can be approved status 1. So they're listed right away and their name comes up for kidney. They're approved status 7. They're listed, but they're on hold. because there may be something else that needs to be done before we can release this patient name so their name can come up for a kidney. Sometimes a patient may be deferred because they're not the right candidate right now, or they may be declined as a transplant candidate. So with successful listing, we are heavily monitored and regulated by UNOS, by CMS, by Joint Commission. So when we're listing a patient, we have to follow their rules and regulation on policy. So for example, as a coordinator, when I list a patient, I have to make sure that a patient have 2 blood types. But when I list the patient, I cannot go back and verify it on my own, because part of the rule is you have to get an independent person to look to make sure you're listing this patient with the right blood type. And that's part of the UNOS and the CMS criteria. So that's how heavily regulated we are. Within 10 days, UNOS says you must send a patient a letter stating that they're listed. You also have to send the letter to the dialysis center. So in saying this, even though most transplant centers may have their own criteria and different ways of how we allocate organs to our patient, we're still regulated heavily. And with that, I am finished. Thank you.
Thank you so much, Maxie and Susan, for this excellent presentation. Maxie, you did say that I know transplant coordinators are the most humble members of the transplant team. You did say that your role is hunters and gatherers. We can see from your presentation that your role is much more than that. Without the transplant coordinators, no patient will be transplanted. Without the transplant coordinators, everything we're saying about removing barriers is not going to work. So your role is much more than that. But again, I do appreciate your humility.